We're at 1:29. We got about a minute before we get started, so I'd like to keep us on time as much as we can.
It's cracking down feathers out too.
Go sit over there in that corner if you don't want to be in the front.
I show 1:30. If we're about ready to go, we'll get this little road show going. Welcome everybody to our afternoon session of our budget hearings. And we have an excited Ms. Buckner coming up.
Ready?
Yes, ma'am. We can't wait.
All right. Neither can I, Senator. I think you all have a handout that we passed out to help you see where we are. Just wanted to put in there first our 23 revenue sources. I thought you might find it interesting. There's still a lot of COVID federal money in there. $3.8 billion was our revenue sources for 23. Our expenditures for 23 are in there. And then you can see what we budgeted for 24. I wasn't going to go over all of those, but I just kind of wanted you to get a little bit of history of where we've come from. We operate 6 major programs in addition to emergency assistance. We're kind of like an umbrella agency. Any one of our programs may be larger than another state agency, depending on the size of the agency. Our first program, and the one that looks the greatest in our budget, is our SNAP program, and that's because of all of the SNAP benefits. We currently serve around 392,000 households, which equates to 776,000 individuals, and of that, about 331,000 are children. So we touch the lives of a lot of people through SNAP. SNAP benefits are 100% federal money coming into the state. States have to pay, it's about a 50-50 match to administer the program. You'll see out of all of those, 96,000 are what we consider head of households over the age of 60 with no earned income. And another thing that I think is very interesting is every month we deny about 18,000 applications across the state. So it's a big program. It's a fast-moving program. One thing that we have seen change in the SNAP program is the emphasis on education and training, and that is trying to get people off of SNAP if they're between work ages so that they can go and make careers for themselves. The next program is the TANF program. This is what used to be called welfare checks. We're down to approximately 5,700 TANF cases, including about 13,000 recipients, and over 10,000 of those are children. So there's really not that many welfare cases anymore that have moms and or dads in the budget. A lot of it is relatives raising children, aunts, uncles, grandchildren, whatever. A component in the TANF program is that you must also cooperate with us in the jobs program, and that is where we give you jobs training, we help you get your education so that you can go forward with a career and support your family. We actually have some people that are on TANF that actually have college degrees. TANF has a lot of supports, so it's a very good program in helping move people into careers and into the workforce. You'll see that last bullet talks about there's 2,372 adult clients in the jobs program, and of that number, 1,468 are employed, which is 62%. But as I said, the bulk of the TANF program is now relatives raising other relatives' children, pretty much.
If I might, just quick, you're saying that 62% of those receiving TANF are employed?
No, I'm saying 62% of those, that 2,372 that's participating in the jobs program are employed. Yes, sir.
Thank you for that clarification.
Yes, sir. TANF gives you a lot of supports after you go to work, unlike the SNAP program. The SNAP program, when you go to work, you're pretty much cut off. That's it. The TANF program, we can pay a year for your child care. We can do some other things for you. If your car breaks down, you can't get to work, we can help you figure out how to get that repaired. SNAP program does not offer that, but the TANF program does. So we've been very successful in moving people to work in the TANF program. On the next slide is about SNAP ENT. We have lots of partnerships. One of our very large partnerships now is with the two-year college program. We've moved a lot of people into getting the job training or education that they need. We're constantly working on new things with them to help get people into the workforce. We also do literacy classes and several other things in the SNAP ENT. We offer that. The child support program serves about 195,000 families in the state. Last year, collections were $357 million. Alabama's paternity rate is something to be celebrated. It's at 98.8% last year, and that's pretty phenomenal because that gives children in the state another set of paternal relatives that if you get into a child welfare situation, you could go to that side of the family to help you take care of the children. It also adds support to the children in the state. The child support is issued on a little debit card. I forgot to say on the SNAP side that it's also a debit card, but it's different than the child support one. And I'm happy to say we've been working with the feds, and hopefully by the end of the summer, we will have a chip reader on that SNAP card, which will help cut down on a lot of the fraud. We've been working with the feds for a while on it, and we hope to bring that to a conclusion late summer. The next slide is child care services. We administer the child care subsidy program for the state. There are about 41,000 children who receive child care subsidies each month in Alabama. Subsidies average around $524 a month. Last year, $262 million was paid out in child care subsidies. Now, this is a program that got lots of federal money when the COVID and ARPA and all of that. So you may have seen in the paper where we gave bonuses to staff, and we did. We had some restrictions in that money had to be sent to providers, but we could restrict some of the things providers did with that money. So it really propped up child care during those years that things were kind of shut down in other areas. We also license and inspect child care providers. The next slide talks about child care facilities. Currently, there's about 1,326 licensed centers in the state. There's 565 homes, and there's 472 exempt providers, which adds up to about 2,363. We're constantly working on licensing more. I think we have about 70 in the pipeline right now that we're working on licenses with. The interesting statistic, we do surveys ever so often. We have since COVID started to see how many centers were back open and all that, how many vacancies they have. And right now, our last survey was about 92% of our centers. I'm sorry, my voice goes up and down. I've got laryngitis this week. But anyway, there are over 17,000 vacancies statewide, according to what our survey results are. And that's pretty in line with what our last survey was. So it may be that child care is not in the right place as far as being available, but there are still a good many vacancies out there.
Commissioner, could you explain exempt facilities? Would that be like church? What?
Yes, thank you so much. Exempt facilities in Alabama, I think we're one of about 7 states that allows exempt facilities. That means you don't have to have a license to operate, but you do have to register with DHR, and you have to be affiliated with a ministry, not necessarily a church, but a ministry, which a church can be the ministry or it can be another kind of ministry. So that's what the exempt providers are. But they are supposed to register, and there's a few other things they have to do with us. Is that all? Okay. We have also been running for the past several years what we call QRIS, and that is Quality Stars also, and the whole purpose of that was to improve the quality of child care in the state of Alabama, because we have a wonderful pre-K program, but you know that baby's brain starts developing from the day it was born. So we were trying to improve the quality of child care through QRIS. When we got the COVID money, the QRIS bonuses were increased greatly, and it did make a difference, because it has not been that many years ago. I'd say probably in the last 5 years, I stood before y'all and said that we have less than 100 facilities participating in QRIS. Well, now we have over 1,900 that are participating in QRIS. Probably a lot of it has to do with how much we were able to put out there in bonus money to the centers to participate in it. But it is a good thing, and it is helping improve the quality of child care across the state of Alabama. The next program is Adult Protective Services, and you will see that last year there was 12,325 reports that we investigated for abuse, neglect, and/or exploitation. We investigate them. Then if there's no family to help the vulnerable adult get to where they need to be, such as a nursing home or some other place like that, then we help get that individual there. The next program that we administer is child welfare. You will see that last year that graph shows that we went out on about 52,305 children that we receive reports on throughout the year. When you look at the next slide, you will see we currently have a little under 6,000 children in foster care. There was a time in this state when we had almost 7,000 children in foster care. So it takes a lot of our partners working with us, especially the court system, the judges, to help move these children through, because the whole system was never set up for the state to be a parent and raise that child forever. So what we look for is to return the child back home to relatives, or if that doesn't work, to help that child find a permanent family. The next slide I thought you would be interested in, the demographics of how many males and females make up that almost 6,000 children. You'll see it's about 50-50 on male and female. The race is 36.9% black, 61.68% white, 1.4% other, and then you can see the age breakdown. The 13 and older makes up 34% of our population, and sometimes they can be a very difficult population for us to serve. The entries and exits into care kind of runs about the same. 3,000 to 3,500 enter, 3,000 to 3,500 exit. It just kind of works out that way. Hopefully one day we will have a lot more exits than we do entries into care. When you look at finalized adoptions, you'll see we had 741 last year. And if you go over and look at the pie chart on discharges from care, that entire kind of different shades of blue area is almost 70% of our children exit care by going to family. That can be mom, it can be dad, it can be grandmama, any relation of kin in there. which we're proud of the adoptions that we do, but we are just as proud of the ones that are able to go back home because the family has made the changes needed so that the child can go back home. The next slide is one that I'm very proud of, and it's the length of time in care, and that's getting children to permanency, and that is a very hard iceberg to move, I assure you. When you spread it out over 6,000 children, and the median length of time in care for those children discharged is now down to 13 months, and you will see that the national median is 17 and a half months. So we're in really good shape on that. Hopefully we will continue to improve. When you look at our independent living program, that's for those foster children 14 and over, we have 1,771 in that category. Of that, last year, 199 graduated from high school, 13 graduated from college. Currently, we have 217 enrolled in 2-year and 4-year colleges, and 21 enrolled in trade programs. Last year, we had a 67%, last time I stood before you all, we had a 67% turnover in child welfare. Last, for fiscal year 23, we're down to 61%, which is not where I'd like to be. That's still an extremely high turnover rate in those direct workers. That is our greatest challenge, along with placements and placement needs. We have quite a few children and youth with mental health needs and juvenile delinquency needs. And we're in the paper all the time about being sued on somebody's case. But it may be because DHR is ending up with most of the children. We've got children that were never meant to be in a child welfare system. We've got children setting fires in our buildings while we're waiting to find a placement for them. We've got workers tied up watching them. We've got workers that have been stabbed, kicked, bit to the extent they had to go to the emergency room. That's hurting us because of our turnover rate. People don't want to work in those conditions, and it's tying up our workers, which we're really short on, for having to stay with that child, because you can't just leave one worker with a child. We are getting children in the middle of the night because mom got a gun off of them. She knows they belong to a gang, and they can't come back to her house. I'm not saying this is happening in all counties, but it's happening in too many counties. And because mom won't let him come back home, they give him to DHR because he's a dependent child because his parents don't want him. So somewhere down the road, we're going to have to deal with those kind of issues and the mental health needs of these children.
Commissioner, can I ask
yes.
a question? Mr. Chairman, if you don't mind. So I was looking back at the pie chart. What percentage are those high-risk foster care kids of your total? Is that on the pie chart? I didn't.
No, that's not on that pie chart. I don't know the percentage.
Just follow up.
I can get back with you on that. I would say it's probably 300, but they take up all our time.
Okay, thank you.
When you're having to rotate workers to stay with them, and you got to have 2 or 3 workers, and then you pay 2 behavioral aides to stay with them too. They're throwing laptops. And actually, in one large county in the state, I hire an off-duty deputy because my landlord says he's going to kick us out of the building if I don't have a deputy on board there with them too. And these were never meant to be foster children. So it's affecting us in a lot of ways because we're trying to develop resources for them, but it's very, very difficult to get an entity out there to take them with those kinds of needs and those kinds of behaviors. Any more questions?
Yes, I have one.
Sure.
What is the solution for the disruptive high-risk children?
I would say everybody needs to step up their plate and do their part of the job that the code requires different entities to do.
Who is everybody?
I would say it's the juvenile court system. Mental health, I know, is struggling to find providers. But the way the code is written for us, it doesn't matter if we've got a provider or not. We have to go get the child and take care of, or the youth. And I certainly sympathize when people don't have providers, because I can't always get providers myself. But it is causing a lot of pressure and stress on the child welfare system. And like I say, it's affecting our staffing, it's affecting our resources that we can develop out there. And once they've committed certain offenses, there are certain facilities that will not take them because of what they've done, so.
Representative Hall, did you have a question?
No. I have worked with individuals in my district, parents who've been frustrated through that process. So I think my question would be, at what point the parents are feeling frustrated, they don't have a recourse, and so the next thing that they know to do is to call the police, which then takes them to a facility or to your organization. What would be the process if that was not the method that they're using? What do you have in place that would prevent that from?
Well, there's supposed to be some community services in all communities that we did as a state years ago to help more kids in the community. Maybe those services need to be looked at. They may need to be tightened up. My heart goes out to those parents. Don't get me wrong. I'm just saying my heart goes out to my workers that are getting kicked and bit and trying to put out fires and getting spit on and all of that. And you expect some of that sometimes, but it's to the level now, it is just way too much of what we're getting. And I know the parents are looking, they call y'all sometimes, they need help. And we do take a lot of kids from the court because the parents can't afford to pay for a child to be in a certain facility. It really wasn't set up to work quite like that. And once we get custody of a child, we're under all these federal regulations that we've got to make sure we tend to and mind the store. And then some of these children it's part of our federal class action lawsuit too, because we need more resources in this state for them. And resources cost a lot of money for this population of children.
Thank you.
Okay.
If I may, to make sure I understand from earlier slides you've had, your total budget expenditure is about $3 billion. Is that correct?
Yes, that's mostly grants and benefits. About 79% of it is.
And of that $3 billion, only what, 2.5% is state funds?
It's not much. I can't tell you exactly. I can figure it up later and give it to you, though.
The overwhelming aspect is federal dollars that's come in that have these programs, and you're suggesting that the state's percentage needs to be increased?
Yes, sir.
Okay. Do you have in here what your total ask is from the state general fund this year?
And it's an increase of about $52 million.
And what's that bring your total to?
It's on over in my presentation.
Just a ballpark, I guess.
Is it 180, Nancy? Total ask this year. General fund. 180. Yeah, yes, sir, it's 180.
180? Mm-hmm. And that's with the 52 million increase?
Yes.
Okay. Now, you've been in this position for how long, Ms. Butler? 15
and a half years.
Wow. Do you remember what your budget was, let's say, 5 years ago? If you don't know, we'll find it.
I've got it.
We have been increasing the funding on this, though, have we not?
You have been some, yes.
Okay.
And then, the COVID money, while it didn't fill a whole lot of things in child welfare, it filled some other things that freed up some other money that helped us shift a little bit too, so.
And now without the COVID money, you're looking to fill those gaps further?
Some of it, but our greatest need is child welfare.
Okay, all right. Thank you.
Okay?
Oh, Representative.
I had just one question. These high-risk kids that you're talking about, do y'all track them after they leave? Do you know what happens, where they end up?
Well, it depends on how old they are. If up till they're 21, they stay with us.
But
If
I
we
mean,
can't rehabilitate them and find a family for them. And sometimes we're very successful with that.
But is a high percentage of them end up in prison or something like that?
I really wouldn't want to say until I've looked at those statistics recently, but some of them do. And it's very sad for them. Okay. If you look at our staff turnover rates, like I say, we were down to 61% last year, but that's one of our greatest challenges, as is our lawsuits, social media, and our SNAP, TANF, and child care computer systems, which we're working on. On page 24, that's just a line graph of our child welfare turnover rate versus the rest of the staff. The rest of the staff's at about 23%. Child welfare, as I said, is 61%. I think a very compelling graph is the one on page 25, where you see like in 07, the staff at DHR was 4,500. You can see in 14 and 17, we were at about 4,100. And we're now at 3,709. So we are not the employer of choice, that is for sure. And then you may talk about the challenges to hiring and retention. Sometimes it's that we can't compete with the wages. More times than not in child welfare, it is the hours required, having to go out at night, and having to go in the homes. It can be pretty scary sometimes. And then you don't always have predictable work hours. And but going out in the field and going into the homes, and law enforcement is good to go with us. They are, but when the deputies have their vest on and their guns pulled and the little social workers there to go in the home to see about the child, it can be quite intimidating. And we do work a lot of females. So they often encounter dangerous and traumatic situations too. But, you know, every time you talk about, it's great and wonderful to add social workers here, social workers there, and social workers here. And but there's only a certain number of social workers. And like I said, we're not the employer of choice anymore. 20 years ago, we were. But as you pull social workers out of that work pool, that's pulling them out of being able to go out and see about the babies at night or whatever to see them. So that is adding to our ability to get workers hired. We've actually worked with state personnel to create another class of paraprofessionals that we're going to have to start using because we can't get enough social workers. And this is a high school degree or a two-year college degree to help us out in child welfare to at least lay eyes on these places. Because when we miss something, that's another lawsuit when a child is injured and we got a report and didn't get out there in time. So again, our litigation, you know, we take up a lot of the court's time between child welfare and particularly child support. So we are involved in about 38,000 cases over a span of a year. We have 51 what we call significant cases. That's people suing us to get a judgment against us. And then we have the class action. So far in the class action, we have spent close to $2 million, but we haven't really started much of anything. We're not finished with depositions and all that. So that's going to be a huge cost for us too. The class action is based on the lack of resources for a population of children that we have, which now, it used to be about 500, it's down to about 300 now. So we hope to prevail in that.
And Commissioner, that's the high-risk kids
Some of them.
related to the litigation, okay.
Some of them are. And then, of course, then you'll see our 25 budget request on page 28. And that is the general fund of 180, as we talked about a while ago. And then we're asking for a little more in the education budget too. So The reason for our request is found on page 29, and you'll see those needs for that 52 million. Some of it's about 5.3 is due to just general inflationary things. Some rates have increased, but the rest of that has to do with the child welfare. And then, of course, we're also being sued about the education of some of these children too, and so we need to develop more educational resources for this population of children too. So we're working on those things though. But again, it does take money to do that. That concludes my presentation. On the back page is just how to get in touch with us. Most of you know that, but we just put the numbers out there just to be helpful. If you've got any more questions, I'd be happy to talk.
Thank you for your presentation. I know your job is challenging, to use a euphemistic term.
It's never boring, I assure you.
I'm not sure that offsets the challenges. Any other questions from any member?
Mr. Chairman,
Yes, sir.
one brief question if I can, Commissioner. The increases that you outline on page 29, are those programmatic expenses, additional staff? What makes up those increases, or both?
29, most of that is to develop resources to serve the children
Okay.
with various needs.
Are we adding staff? I'm just trying to.
Well, I'd like to get staff, but, and of course, we've got that group of paraprofessionals that's in there, but I should be able to absorb that. This money is pretty much has to do with placements. See, these children, according to our federal lawsuit, should be in homes in the communities. And to develop those homes takes an awful lot of wrap services. It takes on-call psychiatrists, it takes on-call psychologists, it takes on-call nurses to deal with some of the needs of some of the children. So to develop those homes, those are pretty high-end homes too. And we have a lot more that need to be developed to move those children out of institutions into those homes.
Very good. Thank you. Thank you, Mr. Chair.
Representative Hall.
Could you tell me a little something about the summer feeding program for children? What are the plans? Are there plans? There was a media report that we would not be able to participate. Are you familiar with what?
Yeah, yes, ma'am.
Could you tell me what that is like, or what that status is, and what are the plans to going forward?
We do not have the funds to run the summer EBT program this summer. The feds did not give us the regs, or we didn't know they were going to do it. I believe it was like June the 14th that we got it, and I think y'all adjourned maybe June 5th or 6th, something last year. So it never came up for us to come to the legislature to ask for additional money for this summer for that program. And so heretofore, the feds had always funded everything, 100% of the administrative cost. And this program, they're not funding 100% of it. States have to have 50% of it. So neither DHR nor State Department of Education had the funds to do that. They've also changed a couple of the regulations, which we feel very strongly is going to make that program cost more, meaning we have to take an individual application on each child that's not already a SNAP or a Medicaid recipient. And that's going to cost more money and more time and workers to do that, which we don't really have the workers to do it. So we would probably be contracting out, which costs more money too to do. So that's where we are. We didn't know it was coming during the session last year, so we could come before the legislature and say, would you like to fund this for us? And neither did State Department of Education. Of course, Dr. Mackey can certainly speak for himself, but he and I have both talked about it. We're both willing to do it. The governor would be willing to do it if there were funding for it.
And so what's the projected cost that you see at this point?
If I might interrupt, just to make sure I understood what that previous answer was. So this is a matter where services were instituted by the federal, and they provided the full funding, and now they're requiring it, but they're taking back the funding.
Well,
Is that what I
We've
thought I
done it.
understood?
We've done it 4 times. Pandemic EBT is something kind of like summer EBT, where you give the kids a card and they have so much. This summer, it's going to be a total of $120, which is the lowest amount they've ever done too. And before, states didn't have to put up any money on the administration of the program. It was 100% federal too, as are the benefits. This summer, it's 50% federal and 50% state, which we didn't know that until about mid-June, that it was going to be like that, or that they were even going to do it. They kept going back and forth on whether or not they were going to do it.
A dime drop. Just the proverbial dime drop.
Yeah.
Yeah.
And there will be a 25 one, but if there's no money to do 25, then I doubt education can do it, and I doubt we can do it too. And we did not put that amount in our budget when we did our budget ask.
Representative Hall, continue. I didn't mean to interrupt.
And so my question was, what would be the projected cost? Do you have an idea what that would look like?
I am not sure. Dr. Mackey and I need to get together and talk about it. I feel like it will be 20 million or more on there. See, before we could use what was called community eligibility school districts and just say everybody was eligible. But on this go around, they won't let us do that. They want an application from everybody unless you're a SNAP, Medicaid, or TANF recipient.
Thank you.
You're welcome.
Commissioner, just want to follow up. First of all, thank you for what you and your employees do. Deputy Landers spent some time with me to better understand the contracted services related to mental health and psychiatric services. But I mean, of course, 25 million of your ask this time, additional budget, is in that area of those high-risk kids. So I think that's kind of where we're focusing on. I would certainly like to see some, if we're able to fund some of that, see some kind of measured outcomes. I mean, because we do know where these kids go, because we place them, right, as the state. I would just like to see that if we do increase funding, do we actually see the benefit of able to move those kids, not to a traditional foster family, but at least to a lower level facility.
We've got that. I can get it for you if you want it now. It's just take me a while to put it together, but we do track that.
Yeah, just curious going forward, if we do increase that funding for those contracted services, not adding employees, but just contracted services, what do we see the value in that?
Yes, we've got some of that now.
Okay,
So,
thank you.
Could all of us get a copy of that?
Yes, ma'am.
any more questions?
Yeah. Any
you
other
so
questions
much.
from anybody? No? Thank you.
Thank you
for
for
your
everything
time.
y'all do. Thank you.
All right. Commissioner Boswell.
Good afternoon.
Good afternoon.
Thank you for the opportunity to present the ADMH budget. Many thanks to the Alabama legislature and Governor Ivey for the investment in mental health over the last few years. Leadership matters, and I'm completely humbled by the partnership and the commitment to the citizens of Alabama. So today we really want to talk about where we're going. To get there, we need to talk about where we are, the gaps in services, and the plan to close those gaps. In our agency, we are transforming every aspect of our operation. Nothing is business as usual. Our destination, every Alabamian in all counties will have 24/7 mental health care access, recovery supports, and live life in the community. So where are we in Alabama? What is the state of mental health in Alabama? You've just heard about workforce. We know that in Alabama, there is one mental health provider for every 850 people who have a mental health need. The national average is 350 people to one provider. So our workforce shortage in Alabama is twice that of the national average, and you've just heard a lot of that from Commissioner Buckner. Also, we know for our adults, we have 21% of Alabamians who are experiencing a mental health issue. That's 797,000 Alabamians. We also have 14% of the Alabamians experiencing substance use disorder. That's 563,000 Alabamians. If you add those two numbers together, it's 1.3 million Alabamians who are experiencing a behavioral health crisis of some sort. That represents 26% of our population. We know from recent polling data that 90% of Alabamians identify mental health as a key priority for the state. We also know that we have 186,000 Alabamians who reported serious thoughts of suicide. We know we have a youth mental health crisis. You've just heard a lot of that from Commissioner Buckner. We know that 13% of youth in Alabama experienced or reported a severe major depressive episode. We also know that 25% of middle school students and 29% of high school students report poor mental health during the past 30 days. So, is it working? What's happening with access to care? That's something that I tend to ask myself every single day. So, if you look at the graph, the black line is the change in the rate of those getting access to mental health care. So, from 2002 to 2020, that is a 32% increase in access to mental health care. Unfortunately, the orange line, which is the rate reporting excellent mental health, in that same time frame, that line decreased by 20%. So access to mental health care is improving. Unfortunately, more people are experiencing a decline in their overall mental health. So identifying the gaps, and we'll start with workforce. Again, we know that in Alabama, there's one mental health provider to every 850 people who have a mental health need. We do know that the previous workforce investments that have been made we're seeing some improvements. We're certainly seeing some improvements at Bryce and Harper Center in Tuscaloosa. We're also seeing some improvements on the provider side, especially with our newer services, our crisis services, our recruitment efforts there are certainly improving. Unfortunately, we're not seeing that at Taylor Hardin Secure Medical. In fact, we hit a critical shortage of staffing last summer, and in May of 2023, we received a demand letter from the Alabama Disabilities Advocacy Program, which puts ADMH at risk of litigation. We also have a critical nursing shortage that has placed our nurse delegation program in jeopardy. And as we've mentioned, the shortage of behavioral health care workforce and lack of competitive wages undermines Alabamians' access to care. So Taylor Hardin Secure Medical. In May of 2023, we entered into a settlement agreement with ADAP, and we agreed to improve staffing ratios in the clinical care at Taylor Hardin. In addition, we are still in a consent decree, Hunter v. Boswell, because we still have 340 individuals waiting in jails for forensic evaluations. We've met the outpatient requirements of the consent decree, but we still have 340 folks who are in jail waiting for an inpatient forensic evaluation. So we need to close the gap for staffing. The plan is to address those staffing needs and the waiting list at Taylor Hardin Secure Medical. We're requesting $9.8 million to meet the staffing ratios at Taylor Hardin that are required by that settlement agreement, and then also $2 million to improve the inpatient services and clinical care at Taylor Hardin. We are adding additional beds to Taylor Hardin. The state has made a huge investment in adding a 96-bed addition to Taylor Hardin. It'll be a net gain of 85 beds, so we're going from 140 to 225 beds to try and address the wait list. The goal is to have all of the beds at Taylor Hardin open by the beginning of October 2025.
May I interrupt you just for a moment? I'm going to make a comment now. This is not, you don't need to respond necessarily to this, but you're telling us about a lawsuit, federal lawsuit you've entered into an agreement on that's going to cost millions of dollars for us to comply with. I also know that Public Health recently, that agency entered into another lawsuit agreement that's going to cost the state millions of dollars. We've got the DOC, of course, that's entered into who knows ungodly number of lawsuits. That's settlements that's going to cost the state millions of dollars, and at that time. Billions, okay. And at the time of entering into these, at what point was a consideration given as to how the funding was going to occur? Is this appropriation by judicial rendering? I'm very concerned. And this is part of the reason I've been asking the questions today as to where we were a few years ago and where we are this year in regards to requests and all the funding requests that's coming in and the impetus of that, and how many of these are from lawsuits that we have agreed to settle without a clear even dissemination of information as to what that fiscal requirement is going to be and how we're going to do it. These obligations are being entered into, and we are not a player in that. We as a legislature, the only thing we get is the bill.
Right.
I don't know about y'all, but I don't know how we can continue in this method. I'm extremely concerned about how we're going to continue with this because we're dealing with things not just in long-term hiring, but in also a construction, and there seems to be no leeway when we come from the judicial side. This is not the way we're set up to deal with business, I don't think, but it seems to be the way. Am I making any sense to anybody here?
Yes, sir.
Where do we stop? How do we deal with that? I mean, these hearings are to ferret out where the problems are and how we're supposed to deal with this, but we can't just take the lawsuit handed off from the nearest courtroom with a bill attached and just cough up the money. How can I say? We don't got the money. The obligations are far exceeding what the potential income is or revenue basis, and I'm not asking for your response necessarily at this point, but I just want to make sure that everyone in this room and in this body understands what the problem that we have here, a continual issue. How many times have we already heard today where we've had federal guidelines, federal programs started, and then they withdraw the money, and we're left holding the empty bag? That is a system that just cannot work here. But it seems to be the way that we're moving. I apologize for my tirade, but those are my concerns, and I wanted everyone to be aware of where we are here, because this is a difficult pattern that cannot continue.
Mr. Chairman, I have a question. Since, okay, we are three separate branches of government here, the judicial hands down an opinion based on a lawsuit, do we have a choice? I mean, we understand the issue is that there's...
Our choice, Senator, is whether the money's there or not.
Okay.
And how do we get it? We got to, whose pocket are we going to pick?
I understand what you're saying, but to me, I see the problem is that the pie is not big enough. We don't have enough money. We don't have enough money. And so...
Tell the taxpayers that.
Well, either we're going to have to expand the pie from some other source, find a way, or I don't know how you sit down and have a conversation with the courts about this as far as, okay, you've handed down this lawsuit, but we don't have the money. Did you take a look at our, our resources as far as our capability of paying this? I understand the frustration. I think we're all there.
I guess part of my frustration is that the executive department, and I'm not trying to cast stones, it's just the way things have developed. They're under the pressure to get rid of. I mean, look at how much money we're spending in attorney fees when we don't settle. And so that's a continuing aspect. And so the pressure is to settle, but that settlement costs money. And yet we don't know anything about it. We, who's in charge of the money, don't know anything about it until after it's complete. And again, we're left with the responsibility without the resources or the answer to adopt or deal with those resources.
All right.
So anyway, I apologize for my tirade again.
No, but they don't have the answers either. It's just that, again, the right to sue is still going to be there. So somehow we can talk about the problem, or we're going to have to sit down and put our heads together to try to find a way to deal with the problem.
But that's the question, Senator, is does the right to sue extend to the right to dip into taxpayer pockets?
You have to ask the courts about that. I don't have that.
So I do want to make just one clarification. The May 23rd is not May 2023 is not a federal lawsuit. It's an agreement that we made with ADAP in an effort to avoid litigation. We do have the existing consent decree. I know I'm making your point for you. 6 of one, half a dozen the other,
okay. A billion here, a billion there, okay.
It's only $9 million.
Nice try, Commissioner.
It's much cheaper, I promise. The other thing that we're doing to really try and address the 340
I can't afford that laundry sale. I'm sorry.
I know.
That's like the ad of buying the car now is going to cost. I apologize.
Yes. So the other initiative that we have is jail-based restoration. So there are 340 individuals who are currently in jail waiting on an inpatient eval. If we can do in-jail restoration and restore them to competency, they can actually go ahead and proceed through the justice system instead of having to come into Taylor-Hardin for an evaluation. So we have trained some of our existing staff as well as UA doctoral students, and those evaluations began in January of 2024. So we're trying to do everything we can to try and get folks out of jail without them having to necessarily come to Taylor-Hardin for an inpatient forensic eval. So our mental health and substance use workforce investment, where are we now? We've just talked about the demand is greater for behavioral health care than the workers that are available to provide it. Over the last couple of years, you've made significant investments in workforce. $15 million has been invested in providing services to our community mental health centers, $2.5 million to substance use providers to address the workforce shortage and the competitive wages. This year, we're requesting $13 million for our community mental health centers and $2.25 for substance use providers. At this time, we are running long waiting lists and providing lower wages for staff, and obviously that creates a barrier to access to care. The long-term solution, one of the long-term solution is shifting to a new business model called Certified Community Behavioral Health Clinics. Certified community behavioral health clinics are being implemented all around the nation. As a department, we received a planning grant for certified community behavioral health clinics, and we're working very hard to complete an application that will provide significant funding for a demonstration to pilot this model in Alabama. Other states have seen significant improvement in recruitment and retention based on this new way of delivering services. Our nurse delegation program is really unique to the Department of Mental Health. The nurse delegation program allows nurses to train, delegate to, and supervise non-nursing personnel. It obviously is a great opportunity to extend our services beyond what a nurse can do in a given setting in the community. It is challenging because more so than any other nurse positions, it is challenging to recruit nurses for this job because they're placing their nursing license at risk by delegating nursing tasks to the individuals they train. So it's a real challenge to get folks to come in and perform these jobs. As you know, there's already a shortage of nurses in Alabama, and there's a well-documented need for competitive wages. That combined with the added risk of folks losing their nursing license means that we need to be able to better compensate those who are performing this task. We're asking for an increase in the provider rate from $8 to $12 an hour to assist with the increased cost of those nursing salaries, and that is an $800,000 request for nurse delegation program. Crisis care, my favorite topic. So for the first 18 months of 988, many of you know that the new 3-digit, easy-to-remember number known as 988 for a behavioral health care crisis was stood up in July 2022. In 18 months, we received over 68,000 contacts. We had no idea when we stood up this service how many folks were going to call, how many folks were going to text, but in that very short period of time, it's 69,000, almost 69,000 contacts. Unfortunately, our answer rate is going down due to call volume. The technology, we've had a couple of technology glitches as well. Our provider capacity to deliver this service is sort of maxed out at the moment, so it is a real challenge for us to meet the demand of those calls that are coming in. We know from that same recent poll that only 20% of Alabamians know about 988, so imagine what happens if 988 really gets out there and the call volume doubles. So we're very concerned about our call centers, and we're very concerned about our capacity to man the 988 call centers. Mobile crisis care, since January, from January to November of 2023, we've served 435 children with mobile crisis team. This is a partnership with DHR that we implemented a couple of years ago, and we've seen lots of improvement in the numbers of children served through those mobile crisis teams in 5 different pilot counties in our state. We also wrote a state plan amendment with Medicaid to be able to bill those services under the Medicaid state plan, and so I believe the end of January we'll begin looking at expanding those services around the state through that Medicaid reimbursement rate. We also served over 4,200 adults in mobile crisis teams, mainly in our rural communities around the state. Crisis centers, many of you have heard a lot about our crisis centers around the state. From May 2021, which is when we opened our first crisis centers, through December 2023, we evaluated 8,200 individuals. Our goal in that program is to keep folks with mental illness from waiting in emergency departments and to avoid jail. 5,700 individuals avoided emergency department admission, almost 1,400 avoided jail, and we had 532 law enforcement drop-offs at our crisis centers. Out of the people we served, 1,454 showed up at a crisis center who were suicidal. So to say that crisis services is saving lives is not an overstatement. There are people showing up at crisis centers who really need those services and would otherwise have nowhere to go. We also served over 2,500 individuals in those crisis centers with a substance use disorder.
And Commissioner, and this includes our veterans as well, correct?
Yes, it does.
Thank you.
So the gap in services, right now, only 24 counties have all three components of the crisis system of care, so 988, mobile crisis services, and access to a crisis center. We also, as I mentioned, have an answer rate that we're not happy with 988. We would like to get our answer rate to 90%, which is the national standard. When those calls are not answered in Alabama, they do roll to another number in another state, but unfortunately, that means that person somewhere else is not going to be able to provide the resources available or communicate what resources are available in Alabama. So the gap in the crisis system of care, we would like to see these services in all 60 counties, 67 counties. We need 11 crisis centers, additional mobile crisis teams, and additional call center capacity. We are once again looking at and considering whether or not the 988 surcharge would be available to fund those additional services. We are requesting $3 million in a general fund appropriation to continue to build out those services. Most likely some of that funding is going to go to try and increase the call center capacity so we can address that issue, which is the most immediate need. Civil commitment beds. So crisis center and crisis center services are wonderful for people who are willing to go to treatment, but most of you guys know that we have folks in our system that often don't want to go to treatment, that are not willing to access care, and sometimes they're a danger to themselves or others. And in order for them to get treatment, they need to go through a civil commitment proceeding. There are not enough civil commitment beds available so that individuals who are committed immediately have a bed available, which means sometimes they go home and they do something, 911 is called, and they wind up in jail. So we're really trying to address this need. We are looking at and having lots of conversations around a sustainable funding source to significantly increase the number of civil commitment beds in our state. Pediatric crisis services, we mentioned our mobile crisis teams, but we are looking at expanding the number of inpatient crisis stabilization beds for kids. There are not enough acute stabilization beds for children and youth, and a lot of times children are transported long distances to receive care, or they wind up waiting in an emergency department for an extended period of time. In one community, 800 kids are being transported out of the county to receive psychiatric stabilization services. The plan is to open a 24-bed child and adolescent unit. That unit will provide direct services to assist with de-escalating the severity of a youth's distress level and his or her urgent care associated with substance use and a mental health disorder. The request is for $1.5 million in operating funds for that child and adolescent unit. Obviously, these are some of the same kids that we've been talking about, that you heard about earlier in Commissioner Buckner's presentation. Here's the other category of folks that Commissioner Buckner and I struggle with almost on a daily basis. We are in desperate need of crisis residential services for individuals with developmental disabilities who also have a mental health issue. We know that more than 30% of the individuals with developmental disabilities also experience a mental health diagnosis. Left untreated, these individuals can escalate to severe behavioral issues. Often these individuals are abandoned because caregivers and providers cannot provide the care they need. Right now, today, we have 90 individuals who reside throughout the state that are referrals from human resources, hospitals, and homeless shelters that are in need of crisis services. Our plan is to develop these services. We have had some good communication with some hospitals around the state and some of our providers who are interested in providing these services. We're requesting $5.5 million in the general fund to address this need. In addition, we also are looking at expanding the services that we provide in the community for people with developmental disabilities. Several years ago, you guys provided the funding for something that we call the new Community Waiver Program. It has been operating for the last few years since November 1st of 2021. Our Medicaid partners worked really literally sort of day and night with us to get this waiver stood up because we felt strongly that we needed this waiver in order for people to be able to live a full life in the community. There are a couple of areas that we found where individuals and families need additional support. They really fall into three categories. One is enhanced behavioral support. So even in the community, our providers need help with learning how to deal with those challenging behaviors that they see in the community so that we can avoid the more costly crisis residential services that we just talked about. Housing assistance is not really covered by the waiver, and so there are lots of folks out there who could live more independently in the community if they had some housing assistance. For the first time in Alabama, we'll be meeting with the Alabama Housing Finance Authority tomorrow to discuss Alabama's application for a 811 HUD waiver for rental assistance. And so we're very, very hopeful that we'll be successful in that application with the collaboration with Alabama Housing Finance Authority. We have a meeting with them tomorrow to discuss that application. We also have some innovative assistive technology that is out there, but people sort of have a hard time visualizing what it looks like. And so we're hoping to stand up 2 mock demonstration homes so individuals who are trying to live independently can learn about the new technology that is available to assist them in their community. Substance use. Okay, so here's the good news for you guys, right? So this part of our budget request was originally in our budget, and then after conversations with the Executive Budget Office and with the chairs of the Opioid Settlement Fund Commission, we actually shifted this budget request to the settlement funds. And so the department is asking specifically for $4.1 million from opioid settlement funds. This year we ran out of state match for Medicaid for people who are seeking medication-assisted treatment. Great news, more people are seeking medication-assisted treatment. Bad news is we ran out of money before the end of the year to cover the Medicaid state match. We had to shift resources from some other projects on the opioid side of things, and so we're really hoping that that Medicaid state match would be there. It's a good sign that we're increasing the number of folks who are getting treatment. There's $1 million in for residential detox. That's a need that we've identified in all of our needs assessments. Every time we do one, detox comes up. And then there's $1.1 million for prevention for programs such as the Youth Fentanyl Challenge. We have to get in front of our youth and talk to them about fentanyl and the dangers of how one-time use can be the end of everything. So that request is actually taken out of our budget request and has been presented at the last opioid commission meeting as a request to the opioid settlement funds.
Commissioner, real quick, so does this also include, you referenced 340 inmates in our county jails. Does this include the money that we talked about using opioid dollars for those in jail assessments and potentially related beds?
So you've heard me talk about 3 categories of people who are in jails today. This is one category. You'll see a bullet up there that talks about the partnership with the county commission. We have lots of folks who are sitting in jails who have a substance use issue. We have lots of counties who have local opioid settlement money that they're not really sure what they can and can't do with it. We are working on a partnership with the Alabama Association of County Commissions to work with those local entities to use that money for an assessment and then work with our substance use providers to be able to then provide the treatment where we can hopefully get those individuals out of jail and into treatment immediately. immediately. And so we're going to start with a couple of pilots. We've talked about a couple of counties. We haven't settled on those yet. But we're really just trying to figure out how to use the existing resources to get some of those folks out of jail. So that's one category. We talked about the civil commitment beds and folks who are winding up in jail because they didn't get to where they needed to be, and then the 340 that are waiting on an inpatient eval for Taylor Hardin.
Yes.
Okay, for a programmatic summary, we are shifting everything in our world. In our mental health and substance use side of the house, for many years, we did either inpatient or outpatient and not much in between. Services on the outpatient side were only available between the hours of 8 and 5. You had 19 different access points with various contact names and numbers, and you had separate services for mental health, substance use, and no primary care. We are shifting to 988 mobile crisis, 24/7, 365 crisis centers, and one point of entry known as 988. It will be integrated care so that mental health, substance use, and physical health will be all in one place. On the developmental disability side, many of you know that we ran institutions in this state for a long time. And then we figured out that some folks were in the community, in homes, and were just as segregated as they were in our institutions. There was little community inclusion or engagement outside of the setting. Day programs were segregated from the community, and folks had limited choice. Today, people are living in their own homes with the people they choose. They enjoy the support of family and friends. They acquire a job, volunteer or retire, but stay engaged. They are able to be a meaningful part and contribute to the community. They achieve their personal potential for independence, inclusion, and self-sufficiency. For the money part of the request, the general fund request is $30.7 million, and that's for workforce investments, crisis care, and enhanced supports for developmental disabilities. The education trust fund request is $8.4 million. Again, workforce investment for mental health and substance use, and the nurse delegation program. That's the summary. So $39.1 million is the total request. And I'll be happy to answer any questions.
Thank you, Commissioner. You mentioned it earlier. You've come a long way since 2019. I applaud you and your department and these House members and Senate members that have bought into the plan and put it in support, as you mentioned. So, questions, members?
Just one. One of the earlier slides you showed, if I read it right, the more you spent, the worse the problem got?
I'm not sure which one.
You had the chart going up with the spending and going down with the result.
So the graph was the number of people who are accessing care, the black line, and then the orange line was people's perception of their overall mental health.
The other question I have is, why are we seeing more and more, or do you know why we're seeing more and more cases?
So COVID didn't help us at all. You know, most of the numbers that you saw today, even though it's a 2023 report, the data's coming from 2020. So right now we really are probably looking at the worst numbers. Everyone's mental health was affected during COVID because we were disconnected from each other. And so some of that we're just now coming out of, but we also see it with kids, that disconnectedness. You know, we've had lots of conversation with members about the use of phones and the impact that all of that is having on our youth. It's sort of a number of things that happened all at the same time to create a pretty negative impact on everyone's mental health. And, you know, I feel like we're like working as fast as we can to improve access to care, but the numbers are kind of outrunning us at this point. And I think we don't know yet all the reasons why the numbers are where they are right now. I think we're learning more every day about why people's mental health is where it is. But a lot of it is a lack of connectedness, a lack of connection to community, a lack of knowing where the resources are. When I hear the stories about kids, it's just heartbreaking because I hear that. I have a daughter who's a principal at an elementary school, and I hear about the little people who are coming in that really, really are struggling. And so we're working very hard to figure it out.
Thank you.
Any other questions from the members? Senator? Oh, that's Pittman's.
Thank you, Mr. Chair. I've been looking at this mental health situation for some years because I have connected with a family that is hereditary. I mean, when you got 12 kids and you got 7 that's mentally ill. And my concern has been long-term care. We need a facility in Alabama that we can take a person, put them there, and get them the proper care that they need. Because if you have a mental person that's out on their own, they're not going to take medicine, they're going to constantly be problems, and in instances probably lose their lives. So I would love to see the state of Alabama have a long-term hospital care facility for mental illness in this state, because we got too many folks walking around here every day that need help. And we're just not offering. I mean, these crisis centers, that's okay for short term, but there are so many long-term conditions that we are not even touching. So I mean, if we're going to spend our money,
mechanism. And we need a long-term funding mechanism.
we need it. I'm telling you, if we sit here as legislators and we pass this stuff off, but we're responsible. I mean, if we can't provide the services that we know people actually need in this state, we're not doing our jobs. And so I want to see that. I'm going to keep saying it. We need a long-term facility in the state of Alabama.
The commitment bed slide was commitment bed / extended care, because you're absolutely right. There's a group of people, you know, in our world, sometimes people don't believe they have a mental health issue. That's part of their illness. And if they don't believe they have it, they're not going to take medication. And sometimes the only way is for those folks to be in an extended care situation where they're supervised and can take their medication. And so it is absolutely a missing link in that continuum. Lots of folks, I would predict, who are in a jail setting right now are in that category of people who just absolutely refuse to take their meds, and there's no recourse for the family or anyone because there's nowhere for them to go.
Because I have also dealing with a case with a family. This guy was incarcerated for 20, 25 years. He received mental health care the whole time he was incarcerated. Now he's out with no place to go. Family has no idea what to do with him because they're scared of it.
Right.
But we released him from a care center into the street with nothing.
Right. Help me.
Any other questions, members? Again, Commissioner, thank you for what you do. Appreciate your passion and your work.
Thank you.
It's reflective throughout your department. Okay, in the final presentation, we're about 15 minutes behind, but Commissioner Azar.
Hi, how are you?
Medicaid. Save the biggest ass for last, didn't we?
Saving the biggest budget for last, I suppose. Good afternoon. How are you all today? I hope you're doing well. First, I want to thank you for allowing me to be here today. As you know, Medicaid has always been an extremely complex program, and as well as you know, it continues to be one of the largest consumers of the general fund as well. As there are many factors that are in our control that affects the budget, there are equally many factors beyond our control that affects our budget. But since COVID, due to the additional COVID dollars, Medicaid since 2020 has been carrying a pretty sizable carry forward in our program. And as you'll see in a moment, that's not any different for this year. And it is clearly good news to be able to have a carry forward in our program, but as history has shown itself, we cannot depend on the fact that we will always have a carry forward. I am so thankful that the legislature supported the Medicaid reserve bill last session. It allowed some of the carry forward dollars to be reserved for when those matters beyond Medicaid's control happen, that we will, for the first time in Medicaid's history, have a reserve fund for that purpose. And I just thank y'all so much for the support of that bill. Man, a lot has happened at Medicaid since COVID and after COVID. Our program went from covering a little over 1 million Alabama citizens to over 1,375,000 citizens in our great state by the time at the end of the declaration of the emergency. So what I'd like to do today is start out with an overview, as I usually do, go over our expenditures and our funding, and then I want to talk a little bit more about our current Medicaid enrollment and our 2025 budget request. Who does Alabama Medicaid serve? I think it's important to remember that we are a categorically eligible state, which means we do have income and resource requirements, right? But you also, in addition to having to meet those, you must also fall into a category. These are the categories that we cover: disabled and blind, children, aged, and other categories. The other categories include pregnant women, our parent caretaker groups, Plan First recipients. And as you can see, looking at the disabled and blind, here I have laid out for you the percent of expenditures. Being obviously disabled and blind is one of our highest expenditures at 46%, at only 18% of our population. You will also see that our children are our largest population at 51%, but are basically our cheapest population. We have our aged, they count 15% of our expenditures and only 8% of our members, and our other categories, 14% of our expenditures and 23% of our members. Next slide. This slide shows our fiscal 2023 Medicaid expenditure analysis. And you can see the pie chart there. It lays out our biggest components of our programs. We have our hospitals, nursing homes, pharmacy, physicians, mental health, alternative care, and I'll explain that a little bit. That includes hospice, targeted case management, home health, and other programs. We have our administrative cost, and then we have our other there, which is pretty sizable at 15%. That includes everything else, basically: our x-rays, our labs, our ambulances, our integrated care networks, our Alabama coordinated health networks, dental, etc. And you can see down at the bottom that our total expenditures for fiscal year 2023 was over $9 billion. So where does all the funding come to pay for that over $9 billion? You can see the significant portion of the dark blue there is the federal funds. And here you'll see it says a 77% federal match. That's still, at the time in 2023, is including some of that COVID-enhanced 6.2 increased FMAP. So that's a higher than usual matching rate. For example, now that we're through that, we're at about 73% federal matching. So this slide still shows some of that impact of the COVID enhanced matching rate. The state funds, as you can see, is at 23% for this purpose of this slide, a little over $2 billion. We have other state share sources that fund as well, which are very, very important, at 14%. Those includes our provider taxes. We have a provider tax for nursing home, hospital, and pharmacy. During the time that this was done, we have most recently included a provider tax for ambulance and intergovernmental transfers from other state agencies, and those type also help provide funding for our program as well. And then the other part of the gray pie is the general fund, which is what is appropriated from the legislature. Also, I think it's very important to remind everyone that we do not get our federal dollars. We don't get the $7 billion, for example, on this slide, just handed to us for a year. We only can draw down those dollars as we spend state dollars. Now, you know, I got this little transition slide here that says Medicaid unwinding, and that may not mean a lot to a lot of people, but woo-wee, at Medicaid it does. I feel as if we've been running 2 Medicaid programs for the last 3 years. You know, being a healthcare agency in a healthcare crisis is challenging, to say the least. So I want to give a little bit of background on what the unwinding is. That is literally a federal term, Medicaid unwinding, which, if we can go to the next slide, Medicaid unwinding is the process that the federal government, every Medicaid program across the nation must unwind. As you may recall, that during COVID, we were not allowed to terminate anyone from our program, even if they became ineligible and should have been taken off. We were not allowed to do so. So we had to keep them on in order to draw down the federal enhanced 6.2% federal matching rate. So once the federal national emergency, ended in May of 2023, the Fed said now every state Medicaid program now must begin unwinding all of those individuals. There's a lot of federal regulations tied around that. Being watched very closely, as I guess we should, since it's a lot of federal dollars tied in there from the federal government. So unwinding is simply the process of redetermining Medicaid eligibility at the end of the public health emergency. The unwinding period lasted for 12 months, during which the states have to initiate and complete the renewal process on all Medicaid eligibles. So what that basically means is we have to lay our eyes on or lay our hands upon every Medicaid recipient on the program to see if they still qualify. And as I said a moment ago, that at the time of the declaration of emergency ended, that was 1,375,000, a little over that, lives that we have to do that over a 12-month period. So Alabama began unwinding in April of 2023 with the initiations for renewals due in June 2023. What that basically means is the agency sends out information to the recipient, and by law, how Alabama's doing this, they have 60 days to respond. So when we send something out, it's not till June that something comes back. We would look at those, take action to terminate if they need to come off the program, or maybe they qualify for a different program, so we move them around. So that's basically why you see the April to the June date. The good news is the agency will finish the initiation as part of the unwinding process this April. So we're on the back end of it, and I can't tell you how grateful and excited I am about that. And those last renewals will come in June of 2024 because of that 60 days I just explained. So then what happens, we have another 90 days. Anytime we terminate anyone in this 12-month period, they have 90 days, and this is an AZAR term where I say rebound back on the program. So they'll have 90 days to come back on retro if they were otherwise eligible and were terminated when they should not have been. It's a procedural termination. There's a term for that, i.e. in most instances, they do not respond to us when we ask for information, or they've already, they could have other health insurance. They know they're not eligible, so they don't want to fill out the information, don't send it back. If they find out that they are otherwise eligible, they can come back on the program. So I tell you all of that to let you know that we will not have a final number of how many people we remove to this program until the end of September of this year, because this number is moving by the minute, because every time we terminate, they got 90 days to come on. So we will not know until that last 90 day runs out after that June 2024. This Medicaid monthly total enrollment, I'm showing this from fiscal year 2020 up through fiscal year 2024. It actually, as you can see, goes to December of last year. It's just a month or so ago. So as you can see, in February, right about the time COVID hit, we had 1,054,000 lives on the program. Then you see the lines start going upward. That's because we cannot terminate anyone. They're going up, and we topped out at the end of the declaration of emergency at 1,375,000, a little over, individuals remain eligibles on the program. And then we begin unwinding, and I kind of show there as it's going down. And as of December of 23, you can see we had 1,229,000 on our program as of December 2023. That number has changed since then because we've got 90 days for the individuals to come back on, and we're seeing roughly around about 25% of those individuals coming back on the program during that 90 days. And that's about where we are. Also, just so anyone knows, that when someone is terminated off the program, in most instances, they are referred to the federal marketplace as well as all kids and other programs so that we can try to point them in another direction if they're not eligible for our program. Next, we got the significant factors affecting our 2025 funding need. Obviously, a carry forward. I'm going to show more about that on the next slide, but we do have a pretty substantial carry forward you're going to see, as well as our program went up, continued to go up as well. Some of those reasons for going up is obviously, goes without saying, inflationary increases. As you can see, I just listed a few here: inflation in nursing homes, pharmacies, Medicare Advantage, and we have that across the board as well in other areas. Other factors that have increased what we're asking for in 2025, the increased federal matching rate, which we refer to as FMAP, ended on December 31st of this past year, but they began scaling that down over the 4 quarters prior to that. So those federal COVID dollars, enhanced federal dollars, are no longer coming in. I think the last quarter, October to December, was about 13 million that came in the coffers there, so we have been preparing for that. We budgeted to not have to be too dependent on that, which is probably another reason why you see such a carry forward that's coming on how we decided to do that. Also, it goes without saying, in any year, utilization of our service, if you have a bad flu season, if you have anything like that, affects our budget. It's really hard to plan for that. You really don't know what's going to happen. And I will say that in fiscal year 2022, we saw an 11% increase in utilization. That was a little shocking to see. I'm not sure exactly why that is, probably due to awareness because of COVID, that I have health insurance or my child has health insurance. Maybe I need to start utilizing the services that I have, not sure. We adjusted our 2023 budget, moving that 11% increase in there to protect us. We rolled it into the current budget we're in now, right, which is 2024, and I included that 11% in the 2025. The good news on that is that has stayed, that increase has stayed, but it has leveled out. So we're not seeing a year-to-year massive utilization increase such as that, which is a good thing as far as budget goes for sure. So here we have our Alabama Medicaid 2025 state funding need. This is the request that we're putting before you. The total funding need, this is a very, very important line, so I want to make sure everyone notices this. Is the total funding need is basically an estimate saying what we are estimating for 2025 to run the program we have right now, okay? You'll see that's $1,135 million of state share for general fund. We had a good carry forward, right? We had $192 million, and I will tell you that is pretty much all related to the COVID dollars we just spoke about. You also see a line, and the governor has to send this budget to you, but I am putting in a Medicaid Emergency Reserve Fund, as you may recall, and I thank you again for that, because I think that's just one of the most fiscally responsible things that could have ever been done for supporting that. It has a $100 million cap, okay, that's great. We had $88 million that'll be going into it from last budget, and I'm asking that we be able to keep $12 million to top it off and be fiscally responsible there to have it at its $100 million. So when we lose control of some of the issues that raise our budget, that reserve will be there to help the state in that instance. So if you subtract off $180 million from our total funding need estimate, you come to the $955 million request I'm asking on behalf of Medicaid this year. Last year's appropriation was $863 million, so you can see that it is continuing to grow, but we're not having to feel the impact quite as much yet because we do have those carry forward dollars. It's one of the major contributing factors for why that request is less than the need that you see on that page. So I know I talk fast, but that was pretty easy. I got right on through that.
Commissioner, thank you. Commissioner took time to meet with myself and Senator Albritton, and seeing a $92 million increase over last year's budget, I knew that you'd want to hear directly from her. So I appreciate you coming here and speaking. Any questions?
Happy to.
Commissioner.
I know you do, but could you provide us with what age groups are on Medicaid? It's 25% of our population, according to the numbers.
What age groups?
Yeah,
well, we cover
by age.
By age, we cover 0 to 19. Is that what you're asking me?
I mean, no, ma'am. You showed there was 1.2 million people on Medicaid as of the end of. I would like to know of that 1.2 million, how many of them is in below 18?
Children, yeah.
Okay.
How many of them is 18 to 30 or 40, whatever you have it, and how many is 60 and above?
Okay. I don't have the exact numbers, but I do have the slide that I came up before that will show you 51% of that number are our children, which is generally under the age of 19, 0 to 18. So we got 51% are our children. We've got 18%, which are our aged, disabled and blind.
Okay.
8% is over the age of 65, and the other categories is like our Plan First, it's parent caretaker group, and like our pregnant women and just other groups that we cover that are generally smaller, and they're about 23% of our population. So our largest population are our children.
Okay.
And if you want specific breakdowns, I can give it to you in numbers.
This is good
after.
enough.
Okay, wonderful.
Any other questions? Yes, Senator.
Thank you, Mr. Chair. I don't have a question. I just have a comment to all of the agencies that came before us. First of all, I want to thank you all for all that you do, you and your staff. Your job is not easy. It's kind of like making bricks without straw. We don't have enough. And somehow we just all have to try to work together. You all are really where the rubber meets the road. It's great for us to sit here and kind of pass judgment or ask why, but that's what we are elected to do, because when we go back home in our districts, people are asking us for answers that we don't have. We really rely on you. And more than once, I know that many of these agencies I have had to call to try to help a constituent in my area. We are all in the same boat, and we all have to work together. We only look good because what you do and the services that you provide. We know that you all have ideas and recommendations about what we can do, but our job is to try to come up with more straw to make the bricks. And so I'm hoping that this legislative session we'll have some legislation that will hopefully do that. But thank you for your service.
Thank you so much.
Commissioner, thank you.
Thank
Appreciate
you.
it.
Wonderful.
So tomorrow, just as a reminder, we'll start at 9:30. We'll have a presentation from Kurt Fulford from our LSA Fiscal Office, and then we will hear from our Executive Budget Director, Bill Poole, and then we'll go into the three categories on the ETF budget. So see you tomorrow. All the spreadsheets and presentations will be on the LSA website, and then once the governor's budget is delivered, then you'll see the actual budget worksheets on the LSA website as well. Okay, thank you. Thank y'all.
See you tomorrow.
Ms. Huntsville, thank you for being here today. Ms. Huntsville, mental health.